Okay.
And this is, I want this to be more question and answer than anything, Rabbi, because I will just throw out information to you.
Okay.
And, you know, whenever anybody has a question, just pop in. And so, for instance, the questions on how long somebody who's had it should remain in isolation, there isn't good data on that. Can someone get it again? There isn't great data on that. It doesn't look like that would be a common thing, but there may be a couple of case reports of that. That right there was somebody wanted some information. I get those all the time. So there are a lot of unknowns here, and that's very important going forward, especially in terms of our isolation strategies. Let me start out by saying that I'm going to talk primarily about the United States. As of about a half hour ago, there were a little over 27,000 cases in the United States. I'm going to tell you the numbers that I think you should pay attention to. The number of cases that are reported is a function of two things. It's a function of how many people actually have it and how many people are tested. So there's a little bit of that that's an artificial number. 1/2 of all cases in the United States come from New York and New Jersey. The number that I think is a little more important to look at, because what we want to know ultimately is are our measures giving us an inflection point? Are our measures stopping the spread? And the answer right now is it's too early to tell. But the two numbers that I would suggest that people look at that are very simple are the number of cases per million in the United States. Currently, that number is we have 83 cases per million in the United States. Now, that's a semi-artificial number too, because of, again, it's a function of testing. New York has so many cases, they have over 12,000 cases because they've done 45,000 tests.
Cory, let me interrupt for just a second. If you could just adjust your camera so your face is more in the...
How's that?
There we go. Perfect. Okay. Thank you.
So they have 45,000 tests. So the number of cases per million is somewhat artificial. It's a function of, again, how many people have got it and how many people we've tested. But the reason I like cases per million as a number to pay attention to is it gives us a trend. It's comparable to other countries, at least in part. And when we get that inflection point, when we get to the point where it's leveling off, that number will level off. In other words, the number of people who become infected will ultimately trump the number of people who are tested so that the number will level off. So cases per million is an important number to look at. And right now it's 82 per million. The other number that's very important, you hear people talk about mortality rates and everything like that. The mortality rate of this in the United States right now is about 1.25%. And there's a confidence interval there between 0 and about 2.5%, which means that, you know, that's the spread with the numbers. But the more important than the mortality number is the number of total deaths, because we have a very reliable system. We have a very reliable system in the United States of looking at deaths. It's a uniform outcome. And essentially, when the virus has stopped increasing, when we have this at an inflection point, what you're going to see is you're going to see the total number of deaths level off. So to me, where you're going to be bombarded with figures and it's be like drinking from a fire hose, the two most important numbers to look at are American cases per million population and the total number of deaths. And right now those numbers are 82 per million cases and 354 deaths. And there are a couple of websites that you can go to that will give you almost minute-to-minute updates on that. I'll stop at that point for a second. Any questions on that? Okay, so the strategy that we're employing here is a social isolation strategy. The rationale behind the strategy is that if we can keep people at a distance, we can retard the spread of the virus and they say bend the curve. So it's going to be a bell-shaped curve. You'll hear people talking about increasing exponentially. Technically, it's not increasing exponentially. What it's increasing is as the first part of a huge bell curve, which is what all epidemics do. And we just don't know what the top of that curve is. And we hope by social isolation, we will spread that out. It appears to have worked in South Korea. It appears to have worked in Singapore. It appears to have worked in Wuhan, although just between us, I don't really trust the Chinese numbers very well. But it's not an absolute strategy. And at some point, we're going to have to make a decision as to whether or not the benefits of a social isolation strategy will be outweighed by the economic benefits, the economic effects. And at some point, that becomes a very pertinent question. And my guess is that that question will come up very seriously in the next 4 to 6 weeks. With such a low mortality in the United States, and the mortality is almost exclusively confined to those over 60 and technically those over 80 and those who have chronic diseases, at some point, we will have to decide whether or not we want to take an intermediate strategy, let certain people come out, go back to work, and max protect those people at highest risk. We're not there yet because we don't have enough data, but that will certainly become an issue at some point in the future. I'll stop again. No questions. Okay. So
I have a question.
sure.
Like everyone, I'm getting all kinds of news feeds and information and, from all kinds of people and sources.
Right.
And I'm hearing people say everything you buy in the grocery store, you should leave out of your home for 2 weeks to make sure it's not infected with the virus before you even bring it into your house. Does this make any sense?
Not much. It's pretty much overkill.
Okay.
We know how long the virus lasts on certain surfaces, and certain surfaces last longer than others, and it's 4 to 8 hours on things like copper, and it's like, I got to look it up, but it's like 2 days on plastic. But that's how long the virus will last, not whether it's transmissible or not. So the answer to your question is, it's leaving it out for 2 weeks is you would probably get more sick from leaving it out than you would from the virus.
My ice cream wouldn't be good.
No, your ice cream.
No.
But I think
That mango ice cream.
if you're really concerned, what you can do is you can simply just use a bleach cloth on the stuff, on the containers and everything like that. And I think leaving out for 2 weeks is probably overkill. Remember, we're talking about gray areas where we don't know for certain, but I would tell you that leaving out for 2 weeks is probably overkill.
Okay.
I have a question. So the overkill area, what about workmen coming into the house? You have a plumbing problem. How about cleaning ladies, that kind of thing? Is that something we should not have anybody coming into your house?
Well, I mean, I'll give you my personal opinion. My personal opinion is I think that and again, this is qualified by saying, assuming you have nobody who's immunocompromised in your house or has no specific risk factor, especially an elderly person, I think that I wouldn't have a problem with it, with the cleaning ladies. I wouldn't have a problem with the plumbers coming in, as long as you keep it to a reasonable number. There's a debate now about how much one-on-one transmission there is and how transmissible it is one-on-one, and there are a lot of variables in that. Probably the greater danger is group transmission when you're in the large groups. South Korea had their problem with a religious group. So a lot of the transmission, the most dangerous transmission may be group transmission. So my personal opinion, and again, it's my personal opinion, is that having the cleaning lady come in or having the plumbing person come in, assuming you don't have someone who's at super high risk in the house, I would not have a problem with that. I mean, we have the plumbers come in. So, I mean, but I'd keep it under 10. Other questions? Yeah, so I think what you're going to see after probably four infection cycles, and 4 infection cycles is defined as an infection cycle is 4 to 14 days. So we're talking about, 16 to 56 days, 2 months. If we go back to the first of the month or the first week in March, you're talking about in early to mid-May, the government, the epidemiologists, everybody is going to have to reevaluate the strategy. And the question will be, they'll have 3 options. And the options will be, will they double down and make it even more social isolation? Will they continue with the current program, or will they loosen it up, max protect old people, and let younger people and certain people go back to work as a way of possibly relieving the economy? I don't know which one they'll do yet. I mean, I can't tell you that. And a lot of it, I think, will depend on what happens in the last week of March and the month of April.
So I have a question with that. So all of us who have to plan what we're doing with our businesses, with our faith-based organizations, are we waiting then to try and take some direction from who? From, what state and federal organizations should we be looking to, or health organizations should we be looking to make a decision if we can open up again, we can send people back to work, we can open the temple again?
Yeah, that's a great question. It's a great question without a real simple answer. Here is, I mean, there are obvious answers. There's the president, there's his top advisors, and Fauci is a very, very reliable advisor. I mean, you can sort of trust him. I worked a little with him in the AIDS epidemic. You can trust Fauci's response to what we do. And then you have state responses. Again, one of the things I pointed out was that half the cases in the United States are in New York and New Jersey. And the interesting thing is the mortality trends are a little higher in the South. And I don't know why that is. It may be older people, smokers, I don't know why. But one of the corollaries to that is, while this is a nationwide problem, it's different in different areas of the country. So they're talking about the surges for the ICUs and this and that. I don't think that's going to happen in a lot of places. I think it may happen in some places, New York especially, maybe California. I think in other places like Illinois, you may see a siege rather than a surge. But the point being that this is a localized thing as much as it's a national thing. So it will depend on what happens in each state. So for instance, Illinois, I think it's going to depend on what we see our transmission there is. And I think the governor then will take the word from his advisors, and he's got the female advisor, I can't remember her name right now, who seems very reliable. I don't know her, but she's very reliable. So I think it's going to be a combination of what the country does nationally based on the epidemiologists advising the government, and the state based on the epidemiologists advising the governor. And you will see different strategies in different states. And I know that's tough in terms of planning, but which is why you want to watch what happens in Illinois. We have right now in Illinois, don't hold me this, but about 600 cases, and we only have 1 death so far. So it will depend on again, I think it's going to depend on the next 4 to 6 weeks as to how liberal they loosen the quarantine rules or how they tighten them. Right now, I don't see a rationale for tightening them that much, which could change, but I don't think that tightening the quarantine rules a lot at this juncture will give you that much more protection versus the effects on the economy. And the effects on the economy cannot be minimized, because if the economy gets hit bad enough, what you'll see other public health problems. I mean, if you go into a radical recession or a depression, you'll see things that the epidemiologists didn't factor in. You'll see things like more suicides, drug overdoses, alcohol deaths, deaths by firearms. You might see fewer motor vehicle accidents, The point I'm making is it will become a very complicated equation, but an equation that you have to pay attention to at some point. Questions there? I'm gonna leave that for you. So I wish I could give you a better answer to that right now. I think it's going to be a combination of national and state to plan for the business or to plan, say, for the temple or something like that. And that will come out of the next 4 to 6 weeks.
So Cory, in this kind of a situation, are the epidemiologists, are the health experts talking to economists, talking to business leaders? I mean, does that normally get balanced out, or is it just one group overriding the other?
Well, Rabbi, that's a great question. And the short answer is I don't know the answer to that. And my opinion is it's very important for the epidemiologists to be talking to the economists and those people, because it's clear now that we have to take that into account. What you don't want, and I don't know if it's happening or not, but it's certainly a possibility, you don't want the single-mindedness of the epidemiologists to ignore those other groups. And I could see that happening. I'm not saying it's happening, but I could see that happening. If you're a kid with a hammer, everything's a nail, as Maslow said. So what you want a sort of a more broad approach with the acknowledgement that the tighter quarantine we put in, the more risk we put the economy. And at some point, the more risk we put the economy creates its own public health problems. So big question, if I was an epidemiologist, am I going to double down in 6 weeks? And they're the experts, but let me advise you that this is pretty much an unprecedented situation in the world. So just between you and me, everybody's sort of playing it by ear.
Yeah, because there isn't really a precedent that could be looked to for guidance in how to address the current situation. Is that what you're saying?
We've had a couple of flu epidemics. The most serious were 68 and 57 before 1919. 1919 would probably be the best model for what's going on right now. It may have killed as much as 5% of the world's population. But the problem was, one, we can't really, they use the epidemiologists. One of the reasons they've created the social isolation model was because of the variable experience of 2 cities in the United States, Philadelphia and St. Louis. Whereas Philadelphia took a rather laissez-faire approach to isolating people and things like that, they had a higher mortality than St. Louis, which took a hardcore approach. And that's the model they use from. The problem is when you're talking about stuff that happened 100 years ago, and there's a lot of stuff that we don't know about what happened 100 years ago. And you're also talking about many, many people in the influenza epidemic died of bacterial superinfections. So we didn't have antibiotics. There were no intensive care units. So that's the closest to what we have now, but everything was different. The other thing that I would, it's my opinion after looking at this data, is you're going to hear on the news and everything, they say, well, we're going to be like Italy, or why can't we be a little more like Singapore, or, England is going to be more like France. I don't think that holds. I think every country has their own variables, and this will be within states too. They have their own variables, and I don't think anybody is going to be like anybody else. Everybody is going to have their own pattern of transmission. They're going to have their own mortality. They're going to have, all these numbers are going to be unique to each general area. So you can't say we're going to be like Italy, or you can't say, why can't we be more like Singapore? There are way too many things, from the way the society is, to the way the government is, to the decisions they make, that render those comparisons not really valid. The only comparison, again, that I like is a hard number of cases per million and absolute number of deaths, because those are the numbers I think are most trustworthy.
How much of an issue is the lack of availability of tests? Is that still a big issue? Has that really affected the number of illnesses or the severity of the illnesses? Is that just something that's being used as a political football, or?
I'm going to give you an 80% political football on that. It's another one. I'm going to give you an 80% political football on it. My belief, underline my belief opinion, is I don't believe we would have attenuated this with more testing early on. You know, if you go back to mid-January, when the United States probably had, let's say 300 cases to make it a reasonable number, 300 cases, which would be 1 per million, you know, and we did have a limited number of tests, and we should have had more tests. I mean, I can't disagree with Fauci on that, but okay, so you've got more tests. At 1 per million, who are you going to test? Who are you going to contact trace? You're going to run out of tests if you know, very quickly, because there's such a low positive rate, and this is such a contagious virus that I don't think that what we did in January made much difference. You know, there's always second guessers, and a lot of second guessers. I didn't see anybody saying that in January. There was probably one of the key spreaders in the United States in January was somebody who visited China and came back to Washington State. But how could you know? How could you know then that would be the person? So at that point, you know, I prefer to look forward rather than back. I honestly don't, you know, if there was anything that might have made a little bit of difference, it was an early travel ban. It probably didn't hurt us to have an early travel ban. When you talk about today, it's still a little hard to get tested in certain areas if you don't meet certain criteria. And again, it's a scarce resource. But I have to tell you, we've ramped up to, I think the number I saw was between 150 and 200,000 tests, which is still low considering our total population. But it's a greater ramp up than any other country has done. I just saw the North Shore numbers because the North Shore people just sent me their numbers, and they've tested about 1,500 people. They have about 250, I'm rounding the numbers a little bit, they have about 250 positive tests, which is about in the range of what I'm seeing. 1 in 6 are positive. And of the 250 positives, about 5% are going to need hospitalization. Of that 5%, about 1% are going to be very, very serious, life-threatening. So those are the current numbers, and they're not unreasonable numbers. The testing, the most important thing about the testing now is that it gives us a better profile of what's happening. I don't think we're anymore at a level where the testing is going to be able to make us do the contact tracing and stuff we're going to do that's going to control it. I think we blew by that exit, and I don't know that we were, you know, it's not like Singapore or Korea. They're smaller countries, they're more authoritarian. I don't think we can do that. And I'm not sure that it would be worth it at this juncture anyway. The testing is important because it tells us what the trends are. That's my opinion.
Yeah, thank you.
I have a question. How serious is the shortage of masks, gowns, gloves that we keep hearing about, respirators?
Just before I got on here, I was in a huge debate where I'm in the middle on the mask issue. And let me tell you, we had an article, I had co-authored an article with Bob Weinstein, who is among the top infectious disease guys in the city. And we worked together for 30 years, and we worked on the AIDS epidemic. So he knows what he's talking about. And he was the primary author of the article, and I was doing more of the editing and, you know, make sure we got word count okay and make sure it's clear. And the one stickler issue for us was masks. And he was fairly strong on masks for the public. Now, I don't have a dog in that hunt. I mean, I'm going to go with what everybody thinks is the right thing to do at that juncture. But I said to him, well, but the CDC is not recommending masks, you know, general surgical masks I'm talking about.
Right.
And so it's hard to write, you know, it's hard to send out an article in the paper saying, you know, you should wear a mask, but the CDC doesn't say that. So we sort of had to finesse the issue. Now, the New York Times yesterday had an article that we should be wearing masks. It goes to, you know, the other countries are doing this and everything like that. The best I can tell you about masks are, and what we did in the article was, it's not unreasonable to wear them in crowded places, you know, again, in large groups. It's not unreasonable to wear them in places like the subway. It's not unreasonable to wear them if you're around people coughing a lot. Whether you're going to wear them consistently and continuously, you know, you run into the fact that over time, the masks become less effective as they get the humidity from your breath. And again, you're going to ultimately talk about a shortage. So I think it's a personal discretion thing. And I think it's a thing where at certain junctures, you might seriously consider wearing masks. But this is, let me tell you, the experts they're both ways on this. And they're also looking at the fact that they're a scarce resource. I think we should be ramping up our masks and the special masks, the N95 for the hospitals. But, you know, it's an open question that nobody knows the answer to. We couldn't even come to a decision on that in this article. And, you know, there's nothing to say you shouldn't wear it, except for the fact that it's a scarce resource. But if you're going to wear it, probably it's not going to help you around the house, I don't think. But you might consider it if you have to go out into a larger group. I don't know if that answers your question. It's a question without a definitive answer.
Well, how worried should we be that we're hearing hospitals don't have supplies they need?
Well, I don't know the answer. I'd like for the hospitals to have all the supplies they need, but I can tell you from personal experience, hospitals don't always use their supplies wisely. Some of the early data I'm seeing is that the transmission between people in the hospitals is not as aggressive as is not as common as people think, but it's certainly, I mean, it's clearly an issue. So, I mean, again, this is going to be a local issue. Every hospital has to marshal their resources and come up with their surge plans appropriately. And my experience, by the way, in talking with a lot of people is to this point, they've been a little laissez-faire about that. So you're having hospitals now that have COVID wards. COVID is the name of the virus and the condition. You're having hospitals that are actually becoming sort of COVID hospitals, and they have to marshal their resources. They have to, it would be good to see a lot more production of resources, ventilators, masks, gowns, and all that stuff. But this is a local hospital thing. And the hospital administrators, you know, they're always in charge, but I've noticed in this one, they're sort of, well, we'll give this to the doctors. You know, the harder the problem, the less they want to be. It's a hard problem. And every hospital, in my opinion, especially with intensive care allocation, has to come up with a good surge plan and a good siege plan. That's not a national thing. I mean, it's going to be, you know, it's going to be bad in some places. It's going to be not so bad in other places. You know, if I'm in the middle of Nebraska right now, I don't see that as a, you know, as a huge issue. But I mean, if I'm in the middle of New York, New Jersey, cosmopolitan area, yeah, that could be an issue. I don't know if that answered your question. So one of the, again, like I said, the trend you want to look at is see what happens in the next 4 to 6 weeks, because that will give us a reasonable idea of whether what we're doing now is working well. And I can pretty much guarantee you that whatever happens, you'll have two camps. One camp will say it didn't work, and the other camp will say if we hadn't done it, it would be much worse. But it'll be the actual numbers that will be telling us something.
So it doesn't appear that climate is affecting this virus at all, that it seems pretty well adapted to temperature and to humidity versus dry. It doesn't seem, are people, is there something to look at in terms of areas that have been hit?
Here's the literature as I understand it, Rabbi. There are a couple of studies that indicate that in higher temperatures and higher humidities, the virus is less transmissible. The problem is those are not population studies. The best case situation for us would be if we got a surge of warm weather across the country and the virus wasn't that transmissible and it would die out, which is what happens with a lot of flu viruses year to year. Right now, if that's happening, it's happening on a subclinical level. I can't tell you it's not happening. It's not happening on a dramatic level at this juncture. It may be happening. It's our best hope. That's the clearly the best hope we have for a quick resolution of this. But if it's happening, it's not happening on a dramatic level. And like I say, one of the trends I haven't seen anybody bring up yet, and the numbers are very small, is that the South is not infected at a greater rate, but the small number of deaths is a little higher. And that, I mean, it may be nothing, it may be a statistical artifact, but it's just something to watch for. And I don't know what that means. It may mean there are more smokers and old people who get in the South. I don't know. And it may be a statistical artifact. But in terms of climate, I keep my fingers crossed that it will happen, but it's not happening dramatically at this point.
So I have another question. You talked about a speedy resolve to this.
Yes.
What is a speedy resolve to you?
Speedy resolve would be that by July, August, we've hit the on the bell-shaped curve, we're on the downslide, that we see the inflection point in end of April, beginning of May, and it's trending down by June, July or August. To me, that's a speedy resolve. I want to see the inflection point where it stops going up in the next 3 to 4 weeks. That's a speedy resolve to me. That's the best case.
And what does that mean in terms of this kind of self-quarantine thing, in terms of, would that be extended?
There you go. You see, excellent question. Again, supposing the warm weather gave us that inflection point, hypothetically May 1st, the epidemiologists would then have to make a call. And that call would be, is what we're doing so effective that we should continue it? Or is what we're doing so effective that we can loosen it? And there are other variables there. And a big variable would be, will the climate change that? So those are, I guarantee you, those are the people at the highest levels should be, they probably are, should be thinking about what will happen if we get that rapid inflection point on May 1st. Should we continue this or should we back off it?
So one of the things that I've heard is that, and maybe lessons we've taken from other viruses, is that, you know, it will go away, but then it will come back. And these were related, I think, to the season. In the warmer season, it goes away, but then in the colder season, it comes back and may come back with a vengeance. Is that?
Nobody knows. Nobody knows. SARS was a big deal in China in 2004, and we really haven't seen it since then. MERS, Middle Eastern Respiratory Syndrome virus, was a big deal in Saudi Arabia in 2012, and we haven't seen that again. The certain thing is we'll get some virus at some point. Whether the coronavirus will come back seasonally or not, or annually or not, somebody may know better than me, but I don't think anybody knows for sure. I mean, there's always going to be a problem. It's just, you know, when it comes up, and one of the things I want to emphasize, and if this is put on hold by July, I can pretty much guarantee you that there's going to be people with cameras and microphones coming to me to talk about the 25th anniversary of the heat wave and all the knowledge we gained from the 25th anniversary of the heat wave, because I was in the middle of that. Well, there are two things that people don't appreciate. The first is that in any situation like this, it takes a while to get your bearing as to what's going on. You know, I mean, we don't know exactly what's going on in the early stages of this. And it takes a while to get the data, to sort out the misinformation and everything like that. That's a fertile area for second guessing, you know. During the heat wave, it was a 4-day thing and it was over a weekend. And people were saying, why didn't he do this right away and everything? Because we didn't know right away what was happening. It's the same here in a little slower motion. It took us a while to get our bearing as to what's going on before we can read and react. That's what I call it, read and react. The second thing that people don't appreciate is, hey, there's a learning curve here. Every decision you make is not going to be the correct decision. The question is, when you made a decision, can you identify that it's not working, that it's an error, and can you correct that? And that's continually going on. When I watch Fauci's body language, I can tell that he's not sure that everything he's saying is going to work the way we hope it works, which is, to me, is good because he understands there's a level of uncertainty there. And a level of uncertainty, that's a big deal in this situation. because there is a lot we don't know, and every day we get a little more information, and you don't want to overinterpret trends. You don't want to misinterpret trends. So there's a learning curve, there's a read and react time, and you know, you just have to deal with that. It's not that easy. Questions, comments, random musings, desultory observations. I don't know.
How scared are you? How scared should we be? Should we be scared at all?
You know, that's probably the most common question I got. I'm not that scared. I think that we should have a modicum of, I would say a little bit of fear, but not a great deal of fear, but a modicum of common sense. Again, this is, you know, we have 350 deaths in the United States now. To have the number of deaths that would actually impact our mortality statistics, the United States has 2.3 million deaths a year. So to get to the numbers where you're talking about tens of thousands, you're talking about 50,000 or above, you would have to have, based on the mortality now, it could change, but based on the mortality now, you'd have to have millions of cases. Now, I can't tell you we're not going to get millions of cases. I don't think that's going to happen. And as it stands now, it doesn't look like the mortality is significant for anybody who's healthy under 60. And the transmissibility, while it's clearly more transmissible than the flu and stuff like that, it's not like measles. So I'm concerned. There's a little bit of fear, but I'm not overly, you know, you should not panic. You definitely should not panic. I know Peggy Noonan wrote an article in the Wall Street Journal the other day, said anybody who says don't panic is stupid. No, that was stupid. You know, when Tom Brady or Aaron Rodgers is on the 30-yard line with 2.5 minutes to go and they're 6 points down, they don't tell their players, okay, let's panic in the huddle. They say, look, let's do what we have to do. And that's the way we should be here. So I'm not overly afraid with what I see now. It's a low mortality situation. I'm actually a little more afraid that the economic consequences of this could be so devastating that that will create more problems. And I think both of those things are things that we have to consider at this juncture. So my simple answer is, Rabbi, I'm a little afraid, but I'm more concerned, wary, just keep your head up and you know, be looking around you at all times, metaphorically. I wouldn't panic, and I don't think people should just go crazy with fear.
So if you were in charge, would you, is there something that you would say we should be doing this differently, or we should, you know, be staying the course right now and continue to evaluate if you were the one who was in charge?
We have to stay the course right now. And we have to look at a couple more cycles. If I was in charge, I would have my smartest people in the room every day. If I was in, you know, big charge, I would have the smartest people in the room every day saying, figure out what we're going to do if the data shows this in a month, or if the data shows that in a month, and make, because again, they're going to have to come at some point to a fork in the road where they have diametrically opposite options. And one is to double down and the other is to loosen. And what I would, if I was in charge right now, I go, tell me why you want to double down, tell me why you want to loosen. If I was in charge in a specific hospital, I would have one well-qualified person in charge of a surge plan saying, okay, your job, don't do anything else all day, walk around for an hour just to see what's going on. But
no,
you come up,
but you know.
You still there?
Yep.
But you come up with the plan on ventilators, masks, gowns, where we put people, what we do with the other people, all those things, more staffing needs. Do we need more staff? Can we get more staff? Can we get people from the community to volunteer? How do we protect them? All those things. So in a local hospital, I would be coming up with a clear-cut surge plan and make sure everybody knows about it and have a central information center. Nationally, I'd say, consider the options based on what happens in the next 4 to 6 weeks. Right now, I think we have to stay the course with what we're doing.
Thank you.
I hope I answered some questions.
This has been terrific. Thank you. It's good to have a calm and knowledgeable person to share these insights and to respond to questions that, you know, all of us have been reading such contradictory pieces from the news, from, you know, and trying to discern what's purely political or mostly political and what's actually helpful in terms of medical guidance and common sense and good healthcare.
Right. There's always going to be political stuff in there. And the best I can say, in my opinion, is filter out the politics. Whether you like Trump, whether you hate Trump, whether you like the Democrats, whether you hate them, you have to filter that out. You have to look at the healthcare people. You have to look at a variety of opinions. And most importantly, you have to look at the data. The other thing, Rabbi, and this is something I learned at the temple a long time ago, the future is a mystery. You know, if there's one thing I wish I could tell you, Rabbi, this is what's going to happen, but I cannot do that. You know, all I can say is, well, I see this trend here and maybe it means that, but I can't tell you what the future is going to be.
Right. Well, Cory, I want to thank you very much, and I hope that we will get an opportunity to talk about your latest book. And to do that, and we'll schedule that. Hopefully, we'll be able to schedule it as an in-person class. But if not, we'll continue to make use of this medium.
And Rabbi, I'm always available. You know, if people if you have a question about the data or the interpretation and stuff like that, because I'm following it very closely. And I'll just give you my best interpretation of what I'm seeing on a macro scale.
Great.
I also do have that phone number for the Northwestern High, specifically about COVID-19. If anybody wants it,
if you can type that into the chat, then people can look at it. And you can send it to everybody, or you can just send it to me, and I can make it available.
Okay, I'm going to type it into the chat right now.
Great.
Okay, there you go. Let's send this.
Joanne, you looked like you had a question or a comment.
Yeah.
No, I'm good.
Okay.
I hope I helped you out a little bit there. I mean,
a lot.
Okay.
A lot. Thank you. Thank you.
Thank you very much.
I hope it was a worthwhile 45 minutes for you.
I don't see it in the chat.
The digit missing. That's not correct.
And it just as a reminder that we're going to take.
Okay, enter.
There you go.
Okay.
Here.
Okay.
So it's 847 Health 9.
847 what?
Health 9.
Oh, thank you.
And as a reminder, we are going to take the recording of this call and we will post it on the calendar in this event. So you'll be able to click on the link and rewatch this call or inform others that this call happened and share any knowledge you want. Thank you all for joining us this morning.
Great.
Thank you very much.
Thank you.
Very informative.
Thank you, Cory. This was great.
Thank you, everybody. Thank you, Rabbi, very much. I hope it helped.
Very much so.
Okay.
Take good care.
Okay, you too. Everybody stay safe.
Absolutely.
Yep.
Okay. Bye-bye now.
Bye-bye.
Bye-bye. Bye.